Welcome to The Inside Track, where we talk all things health, healthcare and medical insurance. Brought to you by TRA and our team of Warren, Alan and Doc Avron. Let's sit back and see what our team has for us today.
Hi everyone, welcome to the 10th edition of The Inside Track. We've got over 5,000 unique viewers to our little podcast channel, which is fantastic.
Well, I'm not so sure if it's a little podcast channel, but it is fantastic.
Good.
Yeah, and I think the points around that is, Warren and Alan, we're bringing relevant medical topics and medical funding topics to our listeners. And on that basis, listeners are finding it very interesting.
Yeah, agree with that.
So for today, you had the chance to speak to a doctor who specializes in allergies.
But specifically, we thought we'd focus on food allergies. Going into summer, going to holidays, all different types of foods are eaten. Let's unpack that a bit, I thought, and understand about food allergies, what the different types of allergies are and how we treat it. And we met this expert physician allergist, Dr. Mabelani. She's a physician allergist, a really, really renowned expert in her field, and it was a great opportunity. So let's hear what she had to say.
Great.
Doc, Mabelani, welcome.
Wonderful. Thank you so much, everyone, for having me today at your podcast. It is such a pleasure to be a part of it. Just to cut short, I'm a mother with 3 kids with allergies, so I'm so excited to talk about allergies today.
Maybe we can start off, because I'm often asked this question: what's the difference between food allergy and food intolerance?
That's a very important question to ask, because a lot of times people think that they're allergic to what they're actually not allergic to. I mean, it's fashionable to say I have wheat allergy or a dairy allergy, gluten allergy. But basically, I like to say to my patients, it's all about the immune system getting naughty. So anything that involves the immune system becomes an allergy. We'll talk about different types of allergy, probably, if you ask me that question. But intolerance means that you don't have the enzyme to break down that particular food. For example, with dairy, you don't have the lactase to break down lactose. Whereas with food allergy, the immune system actually gives that abnormal response, and you start manifesting symptoms towards that particular food that is otherwise harmless to the general population.
Is it inherited or acquired in terms of developing that allergy?
That's a tricky question. Because you can't predict, right? We know that there's genetic predisposition. There's also environmental play in it. So it's epigenetics. But you can't exactly say because my mom has peanut allergy, therefore I'm going to have peanut allergy. Or I can't say because my son has egg allergy, my next child is going to have egg allergy. But there's definitely that genetic predisposition.
So could it be that one has a predisposition to allergies per se? In other words, you're more allergic family than other families. Would that type of inheritance be passed on in terms of just being more allergic to different things than, say, a family that doesn't have any allergies? Or is it very individual specific?
Absolutely. With food allergy, there is an association, especially with identical twins, but certainly with other types of allergy, 50% chance between a mother and a parent with allergic rhinitis and so on. So there is definitely that hereditary element to it when it comes to allergies. Yeah.
Can we talk about you when I asked you the first question, you said if we talk about sort of the types of allergies, but at a very high level, just explain to our listeners what is an allergy, and then maybe try and say with food allergies, which class it fits into.
Okay, so there is different types of allergies means that the immune system recruits different part of the immune system, right? So I like to give an example that we have cops, and then we have the army, and then we have got the FBI, and so that's why we have things like vaccination, because we build, we sort of teach the immune system to build up on certain parts of the immune system. I don't know if that makes sense, but IgE is what is generally known, which is an antibody that is supposed to fight parasites. But in terms of allergies, it comes out and it just gives that abnormal reaction to harmless things. Particularly with food allergy, we have IgE-driven food allergy and non-IgE driven food allergy. And the relevance of that to anybody would be that when you go to the doctor and you ask for allergy testing, they then look for that antibody IgE towards a particular food. So if you think that you're allergic to, I don't know, egg, the doctor would then either draw bloods or do what we call a skin prick test, so that we look for that IgE reaction either in the blood or on the skin prick test, right?
Right.
But when you have a non-IgE, it means it's more of a delayed reaction. So you have a manifestation of symptoms that are delayed, that are driven by eosinophils, and that those kind of cells that sort of come out later on in the immune system. So those would be non-IgE mediated food allergy. And so the presentation completely differs.
Okay, so we've got IgE and non-IgE type of food allergies. Which is more prevalent, or is it not really relevant for our listeners or podcast listeners in terms of trying to understand their allergy?
Yes, it's a good question. And then we have mixed IgE.
Right.
And it gets a little bit confusing. But IgE is what everybody knows. So you have a tree nut, and all of a sudden you start maybe you start itching and you have a swollen eye, and maybe if it's very serious, your chest goes tight and you're feeling dizzy or you collapse, and then you end up in the hospital needing adrenaline or somebody to put up a drip and give some medication. So that would be an IgE. Happens within 2 hours. So that's the common one that we know that present either in children or in adults. Okay, so in children, it's during that food introduction period. As a mom, you start to introduce certain foods, and the highly allergenic foods such as dairy, gluten, egg, peanut, tree nuts, fish, soy, and sesame. During that period, that's when we see that reaction coming up, and mom or dad is able to pick it up immediately because it happens like immediately. And then the non-IgE is the type that is not so common, but also as doctors, we take a long time to sort of diagnose because it's not always straightforward. You know, it's those kids that are failing to thrive, to grow to the standard that we want them to grow to, and they are vomiting and they have diarrhea. And that kind of reaction can actually be confused with maybe it could be a gut infection. Maybe it could be, you know, we're not really sure what's happening with this baby, just an irritable baby. We need to change this milk to that milk. We're not really sure what's going on. So those are the non-IgE because it takes time. It happens over weeks and over months. And the symptoms are very confusing because they're just not in your face immediately.
Okay, so I think that defines the field well in children and adults, the IgE, non-IgE, one's more acute, one's maybe takes over a longer period. Let's just, for our listeners, just try to unpack then what are the symptoms. We have spoken about it briefly, but all the way from the minor symptoms through to anaphylaxis. If someone's experiencing an allergy, what will they feel?
The symptoms are minor, such as where the system in the itch. So you're scratching your skin and you break out into hives, what looks like mosquito bites all over your body. And you can have associated swelling of any part of your body. And it can even affect your nose. So you start having a congested nose. You could start coughing and itchy throat, and then it goes down to the chest, and you can get a tight chest, and you can't breathe properly. You're breathing fast. You're wheezing. You're making a funny sound as you're breathing out. And when it gets to the heart, you can feel dizzy. Young children can't express some symptoms. So you just see them changing behavior. They become very withdrawn. They've had a certain food. And when I first saw this in one of the children, when I was doing an oral food challenge, I couldn't believe it. This bubbly, happy child running around, you give them a food that they're allergic to, and all of a sudden, you know, they're low and they're withdrawn, and you give adrenaline, and all of a sudden that's a happy baby again. So you can have subtle symptoms sometimes, especially in young babies, but clinically, physically, what you see would be what I've just explained.
Okay, great. So as an adult, let's say there's an adult listening, if they're experiencing those types of symptoms, and we're talking particularly food allergies here, when they're eating a particular type of food, right, then perhaps that may require further investigation, and they should speak to their doctors about that. And I suppose you've got to be quite deliberate, right, because you may think, oh, it's pollen and something else, but it actually could be the food you're eating.
Yes, but I would like to just highlight that when you are generally atopic, meaning some people that just have that allergy or the allergic genes. So I could have allergic rhinitis, and then or eczema, and then I go for a food allergy test because I think I'm allergic to a certain food. Just having a positive blood test to that particular food doesn't mean that you're allergic. So a lot of times I've seen people come with blood results and like, doctor, I'm avoiding 1, 2, 3, 4, 5 a list of food that they've previously tolerated because now they think they're allergic based on the blood test. It doesn't necessarily mean that. You have to continuously and all the time see manifestation of those symptoms every time you're exposed to that particular food, every time you're exposed to it. And so we have to be careful when it comes to labeling food allergy.
Right.
Based on just the blood results. In adults, particularly in adults, if you've been tolerating a food throughout, what we see adult onset food allergy would be to fish, seafood, peanuts and tree nuts, particularly those. It's very rare to all of a sudden have an adult that's suddenly allergic to egg or dairy or soy.
Well, that was my next question, right? In terms of, can an adult develop a food allergy? In other words, you've eaten this food all the years through your younger years, teenage years, early adulthood, and then suddenly develop an allergy to it. Are you telling me that's quite rare to happen?
It's quite rare to happen to other food allergens. So in an adult, you can have an adult onset, an adult having food allergy, particularly to fish, seafood, tree nuts, and peanut. That we see. But any other type of food, not really common. Red meat allergy, of course, yes, we see it, where you have a tick bite. I caught you before you asked me, but where you have a tick bite. And then you become sensitized to a certain oligosaccharide. So it's actually a sugar. We're normally allergic to proteins, but this time you're allergic to a sugar that is found also within meat, mammalian meat, red meat. So whenever you eat that red meat, so you're having a braai or you're eating a burger, and all of a sudden you start having symptoms, but not necessarily immediately, even if it's an IgE mediated. This is the only exception. Where you have symptoms 4 to 6 hours later. So you have your dinner, you have your steak at 8 p.m. and all of a sudden 2 a.m. you're waking up with an allergic reaction, you're wondering what's going on. And that would be the red meat allergy. That can also show up as an adult.
So let's follow us through. There's an individual, they suspect they're allergic, they're an adult, they develop this allergy. It seems you are allergic to fish. How would you treat that?
So I would ask you, do you like eating fish? Are you somebody that doesn't mind preparing their own fish at home? Because there's also different types of fish. So if you really love your fish, you would then look into what type of fish. This is not always common, but you can have patients that have mono allergy to a specific fish. So they don't tolerate tuna, but they can eat mackerel or, so you want to give those options. And then you avoid cross-contamination because you can't have it. You can't eat it in a restaurant because, there'll be cross-contamination and you'd react to it. But also fish and seafood. So in the world of allergy, that fish should be separate. Seafood would be all the shellfish, right? They don't have the same allergen.
Sure.
Yes. So if you're somebody that likes, then you can have seafood, shellfish, but then you can't have fish. So it just depends on how bad you want to eat a certain food and how deep can we go into it.
But I say, I really want to eat it. I really want to eat it. Is there a way to actually treat it to get rid of my allergy to the fish? That specific fish.
There is what we call oral immunotherapy, which is not necessarily a desensitization, because what we're trying to do is we're trying to get you to a point where you're unresponsive. So even if you're exposed to the allergen, even though you have not been exposed to it for some period, you still don't mount an allergic reaction towards that food. That's what unresponsiveness would mean of an immune system. And so oral immunotherapy is mostly in children, particularly in infants and toddlers, because once you hit a certain age, it just becomes too difficult and daunting. The success rate has not been that high. But certainly, the earlier you introduce a food, the earlier you introduce oral immunotherapy, the higher the success rate that would be.
So you're saying the earlier you make the diagnosis, the
Yes.
easier potentially than it is to treat and overcome. And generally, by the time you become an adult, it's potentially too late. When in desensitization therapy, when would you use that?
Desensitization would be probably the first phase of how we try when you don't mount an allergic reaction to that food. But what we want is, even though you don't eat that food, desensitization means I'm still giving you the allergen in a dose that you're able to tolerate.
Yes.
But we want you to be at a point where you go for a month without eating peanut. And then the next time you're exposed to peanut, you still don't have an allergic reaction. So that you become unresponsive. Your immune system becomes unresponsive to that particular allergen. So I would say desensitization would be the first step, because you're still exposed to it and we're just making sure your immune system is not reacting to it. But once you're off the food, you must be able to continue tolerating it.
Okay. And is there a way to prevent food allergies? How do we sort of, or if with our kids, as we have kids, how do we prevent that whole food allergy cycle from happening?
Yeah, so in the olden days, I think we were taught if you don't want your child to be allergic to peanut, don't eat so many peanuts when you're pregnant. But now the studies actually show that the earlier you introduce to high-risk children, so those children that have eczema, that have egg allergy, specifically with peanut, because there's an association between egg and peanut allergies. So when you have somebody that's already at high risk of having food allergy, the earlier you introduce the food, meaning for an infant, you would want by 4 months to start introducing foods that are highly allergenic so that they can start tolerating it. That has shown to be beneficial in terms of food allergy prevention. The earlier you introduce the food, from 4 months, the better. In South Africa or in developing countries, we try and say 6 months because we know of malnutrition and things like that. But otherwise, if you can introduce from 4 months, that's good. All these other things, such as prebiotics, probiotics, and fish, omega-3s, and so on, there's still a lot of research around it. There's promising research around prebiotics. But the bottom line is for the pregnant mother to eat a normal diet, eat all the allergenic food, and as soon as the baby is born, 4 months, start introducing the allergenic food.
So the answer is expose your child to as many foods as possible, right? That's
Yes.
actually the current literature. And in that way, you'd probably decrease the risk of allergies developing.
Yes.
Tell us a bit about this meat study. In terms of, in my intro, I said that you've had the 4th largest cohort in the world with red meat allergy in terms of research. Just tell us a bit about that.
Okay, I'll tell you about that. Before I tell you about that, can I just debunk the myth that eczema is not equals to food allergy? So when eczema worsens, don't think, what did my baby eat? What did I eat? But now getting to your question. This was quite exciting because the Australians, Americans, Europeans had come up with their own, case studies that were presented, and then their own research of people being bitten by ticks and then developing an allergic reaction to mammalian meat. And this was labeled as a delayed reaction. So there I was, as I was studying my MPhil allergy and off to the Eastern Cape, there were hearsays that there's people with mammalian meat, red meat, and so how we diagnose food allergy is you have to give the person what they're allergic to. So there's protocols. You give them in small incremental doses and you see when do they have a reaction to it. And so we did an oral food challenge using pork or beef, depending on the religion. And it was a completely different response that I had from the cohort. In the Eastern Cape, because we're used to delayed reaction. I promise you, Aaron, I don't know, that was something else. I mean, it was at Zitulele Hospital, and people were having immediate reactions. So like within 30 minutes, 50 minutes. And what was really interesting about this particular cohort is they had abdominal symptoms as well. So they had severe abdominal pain, which could be mistaken for like food poisoning. You eat red meat and you think,
sure.
So it's food poisoning, and continuously it happens. And so different symptoms manifested, but most especially gastrointestinal symptoms and immediate reaction. So that was completely different from the typical descriptions that we had seen in other countries.
I would not have thought red meat is such a compound that actually provokes allergy, but obviously that's what you're finding, right? How prevalent is that in South Africa?
It depends where you are. So in the Eastern Cape, there were about 155 patients that we had tested. And I mean, there were those that have positive specific IgE to alpha-gal. But when we did the challenge, they did not have a response. So not everybody would, like I say, the blood result would not equal to a reaction. But I can't say, we were not looking at prevalence. So I can't say, but how many people have, what's the prevalence? But I certainly can say if it's the fourth largest cohort in the world, we clearly have a big population, especially in the rural areas where there is, there's farming and all that thing. Yeah.
So if you're eating that burger and you start getting hot and you start developing fever and rashes and symptoms, maybe it's a meat allergy.
It is possible that it's a meat allergy. And there's also alpha-gal in gelatin. So
yes,
yeah, that as well.
Fascinating.
Yeah.
Checho, can you, just to wrap up, just to leave our list, I mean, it's been really interesting unpacking this topic, and I'm sure we're going to have a lot of follow-ups in terms of general and allergies in general. But let's just, to sum up for our listeners, if you want to leave any lasting words, points for our listeners in terms of food allergies, what message would you like to leave them with?
The message would be that if you suspect that you're allergic to a certain food, you have to have it tested together with components to confirm that it is a true food allergy. Do not just have umbrella or blanket elimination of food. And depending on the component, the management is not always avoidance. So there are other options that one can work around.
Fantastic. It's been really insightful. Thank you so much.
Thank you. Have a good evening.
I mean, that is unbelievable, the amount of information that she's able to share with us.
Exactly. And I think it's important for individuals to understand what are the symptoms of food allergy, when they should go to their doctors or physicians, and how it's treated.
Sure.
And I think, I hope that was very informative.
But, at this time of the show, we always look at something sort of TRA gap cover related. And one of the questions that came up on our one of our forums was, can I use my gap cover to extend our medical aid benefits? And clearly the answer is no, because, well, generally no, because gap cover is not a medical aid. But I think I'd like to talk about it in the same breath as we do with you, Alan, regarding healthcare funding, because we're talking about the man in the street faced with this impossible situation where benefits run out. So I think if we can just have a general chat about the fact that you can't use your gap cover to extend benefits, except for a couple of specific areas. But what does the man in the street do to, at this time of year when benefits are running out? And secondly, when there's product choice time, when you're looking at new products for next year. So perhaps just, we can chat about that.
Just to come before Ellen answers, it's like a kid going into a sweet shop, right?
Yeah.
So you offered all these medical funds, all these benefits, and I think in a way consumers are a bit bewildered what's out there.
Sure.
So Ellen, it would be great if you could try and simplify it for our listeners.
Thanks, Doc. Yes, you're 100% right. There are so many benefit options from closed schemes to open schemes in the market. And if you're making use of an intermediary, if you're making use of a broker, ask your broker to do a needs analysis on your own, very, very own, and your family's healthcare needs before you even think about what it will cost, because the broker knows the benefit options of his or her contracted schemes and the benefit design thereof, and will advise you on the best suitable benefit for you. If the benefit exceeds your budget, that's when you engage with the broker, because the broker is accredited and qualified to give the advice, which impact, of course, on financial advice as well. And that's why they have FIS accredited to make sure that they are capable of giving the advice. But fundamentally, start with your own needs, your healthcare needs. Medical schemes will introduce certain mechanisms like co-payments, like tariff adjustments, at above inflation and so on. So it does have a risk for you as an individual, but you must make sure that you understand what those risks are that the medical scheme is trying to manage. For example, let's take co-payments introduction or sublimit introduction. That is to protect the entire risk pool,
Sure.
not just the individual.
Yes.
And that's where a gap product, and that's where we come in as TRA, a gap product can extend the benefit for you.
Sure.
Okay? Either to the need of protecting yourself against what the service provider and specialist will charge or what the hospital charge. And that's where we can provide the extended relief in terms of tariff.
Sure. But I mean, let's put that into the context as well. We're talking about oncology benefits, specifically in the TRA space. We're talking about a sublimit benefit, where a particular aspect of a procedure is limited on an annual basis. There we can help you to extend that. We're certainly not saying that that gap cover will give you an extra 20 consultations and that sort of thing. That's not what we're saying. We're saying in terms of in terms of our product, that's where we can.
So the two areas that it would work are to extend is oncology,
because we've got a product called the oncology extender,
right? Okay.
and that allows you to extend. Let's say your medical aid gives you 300,000 from oncology benefits. We can assist you to extend that a bit in terms of the policy, plus the sublimit area. So, and I guess a nice way to sort of round up for this episode is really to say, we know it's the end of the year. We know you've got questions. We know you're running out of benefits. You're looking at product choice. I think the common denominator among all of this is find a professional to help you.
Yes,
Be it
yes,
your
definitely.
accredited broker, or even if you're a part of an employer group, your HR department, there's going to be someone who you can go to who's able to to give you
The right advice.
Because I was going to say that
information.
we're saying brokers and everything, but there must be some listeners out there who don't have the brokers.
Sure.
Who just maybe direct with their medical fund. What should they do?
They can speak to the fund themselves. They can speak to the service providers themselves.
Yeah, medical schemes has got specialist people in that field, a key account manager or a client liaison officer or a broker consultant or just a call center.
Just a call center. Yeah.
Just call in because the employee of the scheme knows the benefits of that particular scheme best. And that if you are stuck, don't hesitate, call your scheme.
Yeah.
I suppose that's the message.
Sure.
Don't be stuck.
Yes.
Get the information.
But more than that, Doc Efron, we're saying, don't get stuck around a braai and ask your mates to help you to make product choice.
Exactly.
Or if, for the ladies, you're stuck at your little kitchen tea and someone says, I can help you.
That's the
Go to
last
the
thing you should
professionals.
do.
That's the last thing you should be taking anecdotal
Advice.
evidence and advice. We're saying from a TRA point of view, we're in the industry. We know what we're talking about ourselves. And we're saying to you, find a professional, find a service provider. Don't be taking advice from someone off the street, as it were. And I think that's a good
very good message, Warren. Very good.
Exactly.
Message.
And I just want to say to our listeners once again, please send in to Ask Dr. Everyone. We'll put the email address on the podcast. You'll see it flashing before you. If you've got any medical questions or healthcare questions or topics you'd like covered, or any general questions from our panel here, please send them through. We always we're getting a lot of questions in, and we'd love to hear from you.
Yes, thank you very much.
Right.
Thank you, Doc.
Thanks.
Right.
And
Next
thanks
time.
to our viewers.
Yeah.
Thanks, everyone.
Don't stress, the gap is covered.
Well, there we go. Thank you to the TRA team and to you for watching the Inside Track. Until next time, bye for now.